Hello everyone. Myself, I'm Dr. Shemina. I'm doing my senior residency in Department of Neonatology, Jubilee Mission Medical College, Thrissur. And my topic for today is when to put in a tube and the indications. Most common indications for mechanical ventilation is an acute respiratory failure. I would like to discuss a little bit of physiology and mechanism of respiratory failure. The respiratory failure can occur because the brain is not sending adequate signals and there is poor respiratory drive, or there is a problem with the anterior tonsil, the nerve roots, or the neuromuscular junction, or the muscles of respiration. Suppose the brain, anterior tonsil, the nerve roots, the neuromuscular junction, and the muscles of respiration are all working fine. There can be still problem with your airway or the alveoli. If the airway and alveoli is also functioning well, there can be still problem at the alveolar capillary membrane and the gas exchange. So problem at any of these levels can lead to respiratory failure, and it's most commonly classified as type 1 and type 2. Type 1 is hypoxemic respiratory failure because of low levels of oxygen in the arterial blood, and hypercapnic respiratory failure is the inability of the respiratory system to remove carbon dioxide by spontaneous respiratory efforts, or there is an increased production. Type 1 hypoxic respiratory failure is most common. So I will discuss that a little in detail. Can be because of low fraction of inspired oxygen, or it's because of alveolar hypoventilation and the alveoli is collapsed or it's over distended and there's no gas exchange happening, or there is a diffusion defect. This is a normal alveoli and this is a pulmonary blood vessel. Oxygen goes to the pulmonary blood vessel and CO2 diffuses back. This diffusion is directly proportional to the area of diffusion and the partial pressure of the gases, and is inversely proportional to the thickness of the membrane. So this is affected by this diffusion can be affected in the parenchymal diseases, and it can cause hypoxic respiratory failure. Next would be ventilation perfusion mismatch. I would like to explain with a simple diagram. This is a normal alveoli, a pulmonary blood vessel. Normally, oxygen enters and blood with PCO2 enters here and it get exchanged. So normally there is exchange of the oxygen and carbon dioxide. This is what happens normally. In case of, suppose there is no blood flow, so there is no carbon dioxide here, but alveoli is normal and it's getting filled up with oxygen, and oxygen comes in and it goes out, but there is no gas exchange happening. So this is a case of dead space ventilation. There is no gas exchange happening because there is no blood flow here, the pulmonary vessel. Suppose the blood flow is very good, but alveoli are collapsed and there is no oxygen for exchange. So the blood with the carbon dioxide come inside and it goes out. So it works like a shunt. Okay. So pulmonary shunting and dead space ventilation are the causes for ventilation perfusion mismatch. Coming to the causes of hypoxemic respiratory failure in newborns, soon after birth and in the postnatal period. Soon after birth, intrapulmonary causes are hilar membrane disease, meconium aspiration syndrome, congenital pneumonia. Extrapulmonary would be critical congenital heart diseases like TAPVC. Postnatal period, intrapulmonary causes are bronchopulmonary dysplasia, extrapulmonary congenital heart disease with large left to right shunt. Now, coming to the management of this respiratory failure in newborns, it can be either invasive respiratory support or non-invasive. Non-invasive respiratory support is a preferred method and is more lung protective, and there are new emerging evidence to support this. Now, there might be a group of babies where the non-respiratory support fails, and that is when you have to go ahead, put in a tube, and mechanically ventilate the baby. Coming to the causes of indications for mechanical ventilation, that is a respiratory failure is already we have discussed in detail. Inadequate or absent respiratory effort, it's because of frequent apneas, or frequent apnea is more than 6 per hour, or requiring a positive ventilation. Positive pressure, frequent apnea is requiring positive pressure ventilation, excessive work of breathing. Either there is severe tachypnea or severe retraction, high oxygen requirement, FiO2 requirement going up to 40 to 60%, severe respiratory acidosis, pH is less than 7.2 and PCO2 more than 60 to 65. or moderate to severe respiratory distress, but there are contraindications to non-invasive respiratory support like congenital diaphragmatic hernia. In the post-operative period, because of residual effect of anesthetic agents, baby is sedated or baby still require muscle paralysis to maintain a patent airway in case of altered sensorium, to decrease systemic or myocardial oxygen consumption in case of sepsis and severe shock, to stabilize the chest wall in case of flail chest and diaphragmatic palsies. The goals of mechanical ventilation is to improve oxygenation, ventilation, and to reduce the work of breathing. Coming to the clinical conditions, NRP, the most like what we see in a daily practice, it's like a non-vigorous baby who is requiring positive pressure ventilation. Suppose a non-vigorous baby is required positive pressure ventilation with bag and mask for 30 seconds and still baby has not improved. Even after MR SOPA, we like to go for an alternative airway and then give positive pressure ventilation. And before we initiate chest compressions, heart rate is less than 60, we would like to intubate the baby, give positive pressure ventilation, and then continue chest compressions. And congenital anomalies like in case of CDH. Indication to simplify, I've classified as respiratory and non-respiratory, and the causes are different in term and preterm babies. Coming to a case in our unit, so 29-weeker was born to primary gravida mother with history of PH and who had a spontaneous onset of labor pain, so has received 1 dose of steroids 3 hours prior to delivery. And she's delivered a normal vaginal delivery, male baby, 1.1 kg, who's vigorous at birth, Tapkas of 1 minute 7 by 10 and 5 minutes 8 by 10. Baby developed respiratory distress soon after birth. After the initial delivery room management and adequate thermal care, baby was shifted to an ICU with 3-piece resuscitator, and an ICU baby was connected to CPAP with a PEEP of 6 and a FIT of 30%. Initial Silverman-Anderson score is 4, and baby was given surfactant by Lisa technique at 45 minutes of life. 2 hours later, the baby's clinical condition worsened. The Silverman-Anderson score is 7. There is increased FIT requirement of 60%, and you have to increase the PEEP to 8 and to maintain saturation of 90 to 91. And ABG showing severe respiratory acidosis. What would be your next action in this case? The next step would be to intubate and mechanically ventilate this baby as the baby is in impending respiratory failure. There is clinical worsening. There is increased FIT requirement in this baby. Coming to the causes in a preterm, that is first would be a severe RDS, a CPAP or an IPPV failure to give surfactant by Insure technique if LISA is not practiced, or in case of recurrent apnea, chronic lung disease. Coming to the next case is a term baby who is a 40-weeker, 2.5 kg, male baby who was born by LCS, indication being meconium stain amniotic fluid with fetal distress. But baby was vigorous at birth. The Abkhaz 1 minute is 8 by 10 and 5 minutes is 9 by 10. And baby developed respiratory distress immediately after birth. Initial Downey score is 5. Baby was shifted to an ICU and connected to non-invasive positive pressure ventilation with a PIP of 15, PEEP of 6, FIT requirement of 40%. 1 hour later, the Downey score has worsened. Baby is having severe retractions and grunting. There is FIT requirement has increased to 70 to 80%. Clinically, air entry was equal bilaterally. Pneumothorax was ruled out. X-ray is done, showing coarse nodular opacities and good lung expansion. And there's no pneumothorax in the X-ray. ABC done in the right upper limb preductal was showing severe respiratory acidosis with hypoxemia. And echo is also done to rule out congenital heart disease and PAH. In this case, only mild PAH. And the next step in this case management would be to intubate and mechanically ventilate as there is clinical worsening. There is increased FIT requirement going up to 80%. There is failure of non-invasive respiratory support. Which mode we prefer will be discussed in the subsequent sessions. So I'll not be touching upon that. Coming to causes in the term baby, most common is a meconium aspiration syndrome, pneumonia, pleural effusion, pulmonary hyperplasia, pulmonary hemorrhage, and congenital anomalies. Cardiovascular causes, congenital heart diseases, left ventricular outflow tract obstructive lesions like hypoplastic left heart syndrome, critical aortic stenosis, coarctation of aorta, or the right ventricular outflow tract obstructive lesions like critical pulmonary stenosis, pulmonary artery hypoplasia, or hypoplastic right heart syndrome. Or a case of a PPHN, which can be primary or secondary with labile saturations, with pre-post difference of more than 5 to 10, which requiring pulmonary vasodilators. It's better to intubate and mechanically ventilate the baby. Next would be a case of shock to reduce the work of breathing and myocardial oxygen demand. And case of congestive cardiac failure, in case of severe anemia, a large PDA. Neurological causes, most common is a case of severe encephalopathy, birth asphyxia, baby having poor respiratory drive, refractory seizures requiring multiple anticonvulsants, diaphragmatic paralysis, congenital myopathy and neuropathies like SMA and congenital myasthenia gravis. Other miscellaneous causes, a case of NEC with severe abdominal distension, or with intestinal perforation, DIC, and shock, or acute kidney injury on peritoneal dialysis, for neonatal transport in case of critical congenital heart disease on prostaglandin infusions, baby should be stabilized, intubated, and stabilized before transportation. So these are the most common indications for mechanical ventilation. If at all you have any doubts, you can post in the WhatsApp group. And thank you all for listening.